Okay, so after you enter the station, okay, as usual, you will start by introduction and then permission and then open question. What do you mean by introduction? I will introduce myself to the patient and then I will confirm the patient identity. Okay, and then I will move to permission. I would like to ask you a few questions regarding your health and I would like to examine you. Is that okay? Yes, doctor. Then move to open question. So open question, don't ask the patient, came to my knowledge that you have body pain, please tell me more about it. This is not useful. Why? Because sometimes, by the way, the main complaint from outside will be different from the complaint mentioned by the patient inside. And sometimes if you ask open question, the patient will give you valuable information. For example, if you ask this patient an open question, could you please tell me what brought you into the hospital today? Could you tell me, please, what brought you to the hospital today? He might tell you, for example, I have generalized body pain and I have dark urine, doctor. I am not passing enough urine. So from the start, because you asked an open question, he volunteered important information. Generalized body pain plus dark cola-colored urine. From the start, he gave you the diagnosis, right? So asking open question is very important. And by the way, some examiners, if you do not ask open question, they might deduct from skill C, communication skills. So make sure to ask a very wide open question, okay? Then after he mentioned his complaint, try to analyze those complaints. You start by the body pain. Like any other complaint, there is generalized questions you can ask, right? General analysis. For how long has it been going over? For how long do you have this body pain? So, doctor, it's going over for the past 2 days, 4 days, whatever. Here, I will not continue the analysis. No, I will ask questions to squeeze the patient, to squeeze the surrogate about his past medical history. So what about before this 4 days? Were you normal and okay? Is it the first time to get this body pain? Do you have any long-term medical problem at all? Yes, doctor, I have underactive thyroid gland. Here he gave you the first triggering factor or risk factor for rhabdomyolysis. Underactive thyroid gland, hypothyroidism. Still, wait, don't go. Any other problem, any other long-term problem you have at all? Yes, doctor. Recently, my GP started statin, atorvastatin, because I have high cholesterol level. Okay, so here within his past medical history, he gave you 2 triggers for rhabdomyolysis. Okay, at this stage, do not try to analyze them. Don't do the analysis at this stage, because if you do further analysis, the examiner will comment that you are not well organized. The purpose of this question is not to search and do complete analysis for his past medical history and drug history and medication compliance. No, it is just to give you a clue about what could be the problem. For example, my patient presented with chest pain. For how long? For 1 day. What about your health in the past? Do you have any long-term medical problem at all? Yes, doctor, I have problem with high blood sugar, high blood pressure. So here, I came to know that this chest pain might be cardiac. I have to take care. I have to analyze. I have to do full analysis for the cardiovascular system because this might be related to ischemia. Okay, someone who presented with visual loss, you did ask him about the duration of this visual loss. He said it started today, doctor. Is it the first time? But about your health in the past, doctor, I'm a smoker. I have high blood sugar, high blood pressure, high cholesterol level. And then you found that he lost his vision only for 2 minutes and then improved. So what could be the reason here? Any idea?
TIA.
Retinal artery.
Exactly. TIA, right? Sudden loss of vision, completely improved, lasted only for transient period of time. in a patient with risk factors. So this is TIA or MRCP fugax, right? So this is the purpose of asking this question. What about your health in the past? Is it the first time? It is not to do full analysis of the past medical history and drug history. Otherwise, the examiner will comment that you are disorganized. I will just ask him to get idea. However, detailed analysis, I will leave it for the past medical history and for the drug history. Is this point clear? This is very important. Is it clear?
Yes, doctor.
Yes, yes.
Okay, so after screening his past medical history, he will come to the rest of the analysis. How did it start? Suddenly, gradually? Is it getting worse? Is it getting better? Okay, and then is it actually sore to touch your muscles? Is it actually painful to touch your muscles? Okay, so analysis of the body pain finished. I will move to analysis of the dark urine. Okay, so for how long has it been going over? How did it start? Is it getting worse? Is it getting better? I will ask general analysis symptoms, and then I will move to a specific analysis. Specific analysis QCCC. QCCC. Quantity, content, compensation, complication. Quantity, content, compensation, complication. Quantity, content, compensation, complication. So start with, just a minute. So how frequently do you go to the toilet? How frequently do you go to the toilet? And what is the amount of this dark urine? Okay, so doctor, I'm passing very less amount of urine. It's not like normal. Okay, so this is the quantity, amount, and frequency. Then I will move to content. Is it just dark urine, or is it bloody? Is it frothy? Do you pass any gravel? Is it bloody? Is it frothy? And do you pass any gravels? Okay, and then move to compensation. Do you drink enough water? This is very important. Why? Because dehydration is known to trigger rhabdomyolysis, right? So do you drink enough water? And then move to compensation. Complication. So here I will ask about symptoms of uremia. Any feeling sick or getting sick? Any headache? Any mental fogginess or confusion? Any history of fits? I mean seizures. However, don't mention convulsion or seizure, fits, okay? Then I will finish the genitourinary system by,
Sam, again, for
tell me,
complication,
please.
sorry.
Yeah, just search for any symptoms of uremia: nausea, headache, confusion, fits. Nausea, headache, mental fogginess and confusion, and fits. Then finish the genitourinary system by asking about abdominal pain, back pain, loin pain. Okay, so here I finished analyzing the main complaint, both the body pain as well as the dark urine. I will move to constitutional symptoms. Constitutional symptoms, like usual for any case, there is six. It is not six actually. 8 symptoms you need to ask for. Weight is never useful unless you ask about appetite. Because, for example, if the patient has weight loss with good appetite, what could be the differential?
Hyperthyroidism.
Hyperthyroidism, pheochromocytoma, and uncontrolled diabetes.
Hyperthyroidism, diabetes,
pheochromocytoma.
sometimes malabsorption, right?
Malabsorption, yes.
Yes.
Yeah, exactly.
Pheochromocytoma.
Not necessarily pheochromocytoma. Why pheochromocytoma in particular?
Because in
Weight
pheochromocytoma
loss
also,
and good appetite.
yes, the appetite is intact and weight loss is there.
Mhm.
Weight loss is there and
Why
appetite
especially
is not.
pheochromocytoma? Why in particular?
Hypermetabolic.
I mean pheochromocytoma. Yeah,
Hypermetabolic.
any case of hypermetabolic state, hypermetabolic state, can result in weight loss and good appetite. Okay, so weight, always combine weight with appetite. Weight with appetite. Fever and night sweat for almost the same reason, because most of the condition which is associated with hypermetabolic state will result in fever, usually night fever, low grade fever associated with drenching sweat, like what? Like lymphoma, for example, or tuberculosis, as example. Okay, then lumps and bumps and itching. Why lumps and bumps and itching together? Because of the B symptoms for lymphoma, right? B symptoms for lymphoma. Okay, and then very important two questions: dizziness or standing from sitting position, and weather preferences. Dizziness or standing from sitting position and weather preferences. So if the patient mentioned, yes, doctor, I feel dizzy on standing from sitting position, or if he mentioned, doctor, whenever I stand from sitting position, my vision will go dark. What are the possibilities here? What could be the reason? You need, of course, to confirm this within your vital chart, right? You will check the blood pressure sitting and standing, and then the examiner might tell you that, yes, there is postural drop in the systolic blood pressure of 20 on standing from sitting position. What could be the differential diagnosis?
Hypovolemia, dehydration, anemia.
Okay, so dehydration and decreased blood count. I mean anemia, right? Hypovolemia. What else?
Addison disease if long term.
Hypopituitarism.
autonomic failure, autonomic bro.
If you
failure,
say
like muscle failure.
hypopituitarism, if you say hypopituitarism, okay, this will take us to another question. Which one is more likely to cause dizziness and standing from sitting position? Primary hypoadrenalism or secondary hypoadrenalism? I mean hypopituitarism. Primary more than secondary, right?
Primary.
Primary more than secondary, exactly. Okay, because here you have problems with electrolytes, you have water loss, in addition to low cortisol. Low cortisol, yes, will affect the vascular tone, and this might result in postural hypertension. However, if you combine this with water loss, here the dizziness will be remarkable, right? Significant dizziness. However, in case of secondary hypoadrenalism, I mean hypoadrenalism related to the pituitary, mineralocorticoid pathway is entirely normal, right? No problem
Yeah.
with the mineralocorticoid activity, because here you need
Process.
renin, you need exactly renin, and then it will be converted to angiotensin 2. Kidney and lung are involved in the process. However, the pituitary has nothing to do. I mean, suprarenal gland and the lung. Pituitary has nothing to do. If you have problem with the pituitary, the mineralocorticoid activity will still be normal. So let us say Addison, better than hypopituitarism. So if you check the differential for dizziness on standing from sitting position, all of them has D on it, like Addison, diabetic autonomic neuropathy, drugs such as what? Diuretics, dilators, I mean ACE inhibitors, decreased blood count, anemia, dehydration, all of them has D on it. All of them will cause dizziness or standing from sitting position, I mean postural hypertension. Okay, so this question is very important: dizziness or standing from sitting position. And then any weather preference, or you can say, are you abnormally sensitive to hot or cold weather? Are you abnormally sensitive to hot or cold weather? Okay, this patient is hypothyroid. This question might be positive or it might not be positive, because in case of rhabdomyolysis, usually the patient will feel hot. It is not significant fever. However, he will feel hot, right? After analyzing the main complaint, I will finish the general symptoms. Finish the general symptoms, I will move to systemic review. Systemic review here, cardiovascular system is very important. As we mentioned, there is chance of arrhythmias here, right? From sinus tachycardia up to ventricular ectopic beats, and then atrial fibrillation, ventricular tachycardia, ventricular fibrillation, and even cardiac arrest. All of them can happen in case of rhabdomyolysis because of electrolyte imbalances mainly. However, the patient might present with chest pain. Why chest pain in a patient with rhabdomyolysis? An idea?
Maybe muscular.
Your voice is
Osteochondritis.
breaking. Osteochondritis? No, not osteochondritis.
Maybe muscular pain. Muscular pain.
Yeah.
This is related to the direct effect of myoglobin. It can result in direct effect to the myocardium, okay, and then result in myositis and chest pain. Your voice is breaking, doctor. I don't know if this is from your side or my side. Okay, so within cardiopulmonary system, I need to ask about palpitations and chest pain. Most importantly, palpitations and chest pain. However, take care not to mention jargon. Any problem with your heart, like heart racing, okay, any pain in the chest, and then move to genitourinary system. Here, the patient might have abdominal pain, diarrhea, or constipation. Anything can happen because of the systemic inflammatory response, because of the electrolyte imbalances, metabolic acidosis, dehydration. All these problems will cause uh, alterations in the GI system. Anything can happen: abdominal pain, constipation, diarrhea. Okay. Then musculoskeletal system here is one of your involved system, right? So you need to do deep analysis. Most importantly, it is not only muscle pain, by the way. Muscle pain, swelling, tenderness, weakness, stiffness. Pain, swelling, tenderness, weakness, and stiffness. So, however, particularly muscle swelling, if there is significant muscle swelling, for example, in the calves or in the forearm, which complication you need to look for here?
Compartment syndrome.
Exactly, compartment syndrome. Sometimes the swelling will be significant, the area will be tense, and it can result in compartment syndrome. So it's very important within the CNS to ask about numbness in the hands and feet. Most common place for compartment syndrome is legs, calf, and forearm. So ask about numbness, especially affecting the hand and feet. Of course, you need to start first by umbrella question. Any change to sensation at all? Any change to sensation at all? Okay. Then ask about numbness or tingling or pins and needles affecting the hands and feet. So if this was positive, you need to mention to the examiner, okay, that this patient needs immediate assessment by the surgical team. He might be developing compartment syndrome and he might need urgent surgery for fasciotomy, right? Fasciotomy. After you finish the systemic review, you will move to PDFs, post-medical history, drug history, family history, social history. So within the post-medical, he mentioned hypothyroidism. He mentioned hyperlipidemia. Here, I will do full analysis. For how long have you been diagnosed with underactive thyroid? Which treatment you are using? Are you compliant to the treatment? Did you develop any side effects? And then move to hyperlipidemia. When were you diagnosed with high cholesterol? When did you start the statin? It's very important to ask this question. When exactly did you start this statin? Okay, because you need to relate the development of symptoms to starting the medicine, right? Then also make sure to ask about recent infection or trauma. Recent infection or trauma, recent vigorous exercise. So within the post-medical history, try to explore the post-medical history very well. Hypothyroidism, hyperlipidemia, recent infection or trauma is unlikely. However, you need to ask recent vigorous exercise. Okay. Social history, like usual, smoking, alcohol, job, and hobbies, and so on. However, when you come to the family history, sometimes if the patient has multiple problems like body pain, he has hyperlipidemia, hypothyroidism, okay, If you ask any family history of similar condition, this question will be confusing. Better to ask specifically. What are you asking about? Is it myositis? Okay. Any family history of problem with the muscles? Ask direct question to avoid confusion. Okay. If the patient is already diagnosed, for example, with a particular medical condition, then you can ask any family history of similar condition. However, since here we do not have a clear diagnosis, we have multiple medical problems, we need to be more clear. Any similar condition like muscle problem, like high cholesterol, like underactive thyroid gland or problem with the thyroid gland, okay? Clear? Then ask about consent and start examination. First, ask about consent and start examination. Why? Because sometimes, by the way, the patient might have many concerns. Sometimes he will give you a paper which contain like 5 concerns. Happened to one of the candidates. She went for the exam in Adman Center. So her case was primary hypoadrenalism, Addison disease. She spent too long time exploring the history to try and identify the underlying cause. Travel history, sexual history, searching for HIV, a lot of history. And then before starting her examination, the examiner told her 2 minutes remaining. So she couldn't know whether to ask history, to complete the history, or to start examination, or to start addressing the patient concern. So she spent another 1 minute examining the patient. Then only 1 minute is left. When she asked the surrogate, "What's your concern?" he gave her a paper. In that paper, there are 5 concerns. 5 concerns. And only 1 minute left. She could address only one concern, and then he could not respond to the rest of the concerns. I think in skill F, they gave her like 1 out of 4. However, she passed the station because in other skills, she did very well. So that's why better to ask about the concerns before starting examination. If the patient have many concerns, then you can adjust your examination to leave more time for the discussion, because you will need to address the patient concern, explain the diagnosis, possible triggers, how are you going to deal with them, management plan. Okay, so usually you will need like 3 minutes. In average, you need like 3 minutes. However, if the patient mentioned a lot of concerns, "Doctor, what's wrong with me? Is it serious? Is it treatable? Will my family get it? Will my children get it? Is it cancer? Is it..." Sometimes they will have many concerns. So here I will manage to finish my examination quickly to come back to explain to the patient. This is very important. So do you have any concerns for me? He will mention, "Doctor, what's wrong with me? Is it affecting my kidney? And is it related to my recent medication?" So 3 concerns raised in the exam in this case. Okay, I will address all of your concerns. Before that, I would like to examine you, if that is okay. "Yes, doctor, please go ahead." Here, examination in the long clinical consultation, always use the same approach. If you use the same approach again and again, it will be printed at the back of your mind. When you go to the exam, you will not forget any part of your examination. Okay, so just like Dr. Riham did, you will start by the vital chart. Okay, at this, as soon as I start the examination, I will look to the examiner. At this stage, I would like to check the patient vital chart. I would like to check the patient vital chart. Sometimes it will be mentioned from outside. Sometimes the examiner will give you the vital chart inside. After the vital chart, you will add bedside test. For example, in such patient, my concern here, one of my concerns is dehydration, right? It is one of the triggering factors for rhabdomyolysis. So I would like to check the blood pressure sitting and standing. I would like to check the blood pressure sitting and standing. I would like to dip the urine to check for any evidence of myoglobinuria. I would like to dip the urine to check for any evidence of myoglobinuria. By the way, urine dipstick will be positive for heme, not myoglobulin. Okay, so it can be myoglobinuria, it can be hemoglobinuria, and it can be red blood cells. You need to confirm this by urinalysis during your investigation. Is it clear so far?
Yes,
So
doctor.
I will start by vital chart, and then blood pressure sitting and standing, and I would like to dip the urine for myoglobinuria. And then start examination of the main complaint. The patient is complaining of pain throughout his body, all of his muscles. Okay, so I would like to examine you now. During my examination, if you feel any pain or discomfort, please let me know and I will be gentle. Okay, doctor. Here I will start by palpating very gently, just soft touch. Palpate for muscle tenderness over the thigh and shoulder. Thigh and shoulder, okay? However, depend on history more than really examining for tenderness. Don't press too hard, because if the patient, if you cause physical discomfort, this will affect patient welfare, skill G. Okay, so just pretend to be touching. So is it so if I press here? Yes, doctor, it is very painful. Okay, so positive for tenderness. No need to squeeze the muscle, okay? So tenderness, then check for swelling and firmness. Swelling in the thigh, not thigh, sorry, in the calves. If the calf is tender, hot, firm, and painful, what do you think here? What do you need to look for?
DVT.
Excellent. DVT and also compartment syndrome, right? It could be DVT if the patient was immobile, for example, for the previous 2 days, then he can develop DVT. And then if the swelling is significant and the area is tense, ask about numbness in the feet. Okay, because your main concern here is compartment syndrome and DVT. Compartment syndrome and DVT. Then just quick estimation for the power. Are you able to move your upper limbs? Are you able to move your legs? Assess for any weakness. So usually the weakness will be because of the pain only rather than true weakness. After examining the main complaint, you will move to general examination. General examination here start by palpating the thyroid, for example, to look for any evidence of goiter. Okay. Within your vital chart, if, for example, there is bradycardia, what could be the possibilities in this case? There is bradycardia in the vital chart. What could be the possibilities?
Heart block.
Hypothyroidism.
Dehydration.
hyperkalemia, hypocalcemia.
Okay, what else? It could be hypothyroidism, right? If, for example, the patient's skin is dry, dryness of the skin, dryness of the hair, constipation in the GI system, cold intolerance in the constitutional symptoms, then bradycardia can be justified by hypothyroidism. However, most of the time it is going to be tachycardia. Tachycardia. There is muscle destruction, there is systemic inflammatory response, stress, dehydration, acidosis, a lot of problems which might give sinus tachycardia, right? Anyway, you need to check the pulse. Be careful when you ask for the vital signs. Then it's important also to examine the cardiovascular system. Just auscultate the lung for any irritations, fluid overload. Because of what? Myocarditis and sometimes heart failure can happen. Okay. Then lower limb, inspect for edema related to renal failure. However, in acute AKI, which is associated with dehydration, it is unlikely to find signs of fluid overload, right? After you finish examination, as you mentioned, vital chart, then examination of the main complaint, then general examination. After examination, I will come to explain to my patient. Again, fixed way of explanation. Disease plan advice. Disease plan advice. I'll explain the disease. I will explain the plan of management. I will give the patient advice. This advice sometimes might be stop driving, stop smoking. Or it can be, for example, do not overexert yourself, drink plenty of fluid and maintain well hydration. It depends on your case. So disease, I suspect you have a medical condition known as rhabdomyolysis. I mentioned the name of the disease. So this condition happens when your muscles get damaged and break down. It happens when your muscles get damaged. This will release stuff from your muscles into your blood. No need to mention deep medical terms, myoglobulin, potassium, calcium. No need for this. Keep it simple. So this release some stuff from your muscles into the blood, which can then cause problem with other parts of the body, like problems with the kidney, problem with the heart. So here, in simple way, I explain rhabdomyolysis and the complication, possible complication, AKI, heart problems. Then I will come to the cause. So the medications which you are taking for high cholesterol and together with your underactive thyroid gland, vigorous exercise, not drinking enough water, all of them can contribute to this condition. It can contribute to your muscles damage. Okay, is it clear? Shall I repeat again?
It please. Yes.
So I suspect you have a medical condition known as rhabdomyolysis. It happens when your muscles get damaged. This will release stuff from your muscle into the blood, which can then cause problems, like problems with your heart or kidneys. So the medications you are taking under active thyroid gland, vigorous exercise, not drinking enough water, all of them can contribute to your muscle damage. All of them can contribute to this problem. Disease finished, I'll move to plan. We need to admit you to the hospital. We need to admit you to the hospital. First, to run some investigations to confirm the diagnosis, right? Then, to give you safe painkiller and fluid through the blood channel to help protect your kidneys. Why did I mention safe painkillers? By the way, you cannot give non-steroidals. It is not because non-steroidals will cause rhabdomyolysis, like Dr. Riham said. Dr. Riham is here? Dr. Riham is here or left maybe?
Because the
Yeah,
non-steroidal will worsening the AKI.
exactly. AKI. It will worsen the AKI, yes. And also it will worsen the hyperkalemia. This patient has got hyperkalemia, right? So if you start
Yes.
non-steroidals, it will put extra risk on the kidney, and also it might increase hyperkalemia, and hyperkalemia might result in arrhythmias, including cardiac arrest. So better you go for paracetamol, or if the pain is severe, you can start opioid, but avoid non-steroidals. So we need to admit you to the hospital to run some investigations to confirm the diagnosis. We will give you safe painkillers and fluids through the blood channel to help protect your kidneys. We will monitor salts in the blood and maintain them within normal levels. It's important to monitor your heart for development of any complications. Plan finish. Move to advice. Here you can tell him, for example, we might need to change your cholesterol lowering medication to another safer option. Okay, it's important to drink plenty of water, to remain well hydrated. Do not push too hard on your muscles during exercise, especially if you are not used to it. However, it is not necessary to mention all the management plan at this stage. You are just discussing in brief with the patient. Still, we need to confirm the diagnosis, right? Even in reality, if you receive a patient, you will not explain full details of the management plan. You will tell him, for example, we need to admit you to the hospital to give you some fluids. We need to run some investigations to confirm the diagnosis, right? Don't worry, I will give you safe painkillers to help with the pain. So keep your explanation brief. Anyway, you will cover any part and you can explain your knowledge during the discussion with the examiner. So examiner's question, the first question is going to be, what is your diagnosis? What is your diagnosis? So I need someone to give me the diagnosis in this case. Anyone wants to try? What is your diagnosis?
Acute kidney injury, acute renal failure due to rhabdomyolysis.
Okay, if there is clear findings suggesting renal failure, you can mention this. However, in this scenario, there was no clear evidence that the patient is on renal failure. So better not to mention this. However, my point is, whenever you want to mention the diagnosis, whenever you want to mention the investigations, whenever you want to mention the treatment plan, you have to cover the diagnosis, the underlying cause, complication. Diagnosis, underlying cause, complication. So triple C and sometimes also A, triple C and A. The first C, confirm the diagnosis. The second C, search for the underlying cause or sometimes trigger, like in our scenario, triggers. Third C, search for any complications. And then the A is for associations. So I will not tell the examiner my diagnosis is rhabdomyolysis and then keep silent. He will never give you the same score as someone who mentioned everything without further questions, without the need for the examiner to ask you a lot of questions. What else? What else? What else? Okay. So from the start, what is your diagnosis? This gentleman developed rhabdomyolysis due to a combination of statin use, hypothyroidism, and overexertion. This gentleman developed rhabdomyolysis due to a combination of statin use, hypothyroidism, and overexertion. I would want to admit the patient urgently to the hospital for fluid support and electrolyte correction to prevent the development of cardiac and renal complication. If you mention this way, he will give you the full mark in skill D because you mentioned the full diagnosis,
Can you repeat?
full problem list. Sure. So this gentleman developed rhabdomyolysis due to a combination of statin use, hypothyroidism, and overexertion. So here I mentioned the first C is rhabdomyolysis, right? Second C, cause or trigger, statin, hypothyroidism, overexertion. Statin, hypothyroidism, overexertion. What about the third C, complication? I would want to admit this patient urgently to the hospital for fluid support and electrolyte correction to prevent the development of cardiac and renal complication. Clear? So the second question was, are you aware of any other risk factors which might result in rhabdomyolysis? Are you aware of any other risk factors which might result in rhabdomyolysis? So I will give you a small mnemonic to help you remember. I don't think this is necessary. However, anyway, the mnemonic is SMASH. SMASH. Just a minute, let me share it to the screen better. Are you able to see the screen? You can take a
Yes.
screenshot of this. So the S is for statins and other medications. Even fibrate, by the way, it can cause myositis and contribute to rhabdomyolysis sometimes. It is not completely safe. Bravastatin, rosuvastatin are better options. Ezetimibe, monoclonal antibodies, okay? However, statins. M is for muscle exertion, any pressure on the muscle. This can be vigorous exercise, it can be convulsions, it can be crush injury, burn, any stress on the muscles, muscle exertion or muscle stress. Then the A is for alcohol and absence of fluid, I mean dehydration. Alcohol and absence of fluid, which is dehydration. Then the second S is systemic conditions, like what? Hypothyroidism. By the way, hypothyroidism per se might increase the risk of developing rhabdomyolysis. You need to combine this, of course, with other factors like dehydration, statin, okay, injury, or overexertion, anything. However, per se, hypothyroidism per se is known to be a risk factor for rhabdomyolysis. Then the H is for heat stroke. Heat stroke. Then the next question is going to be, should ask, yes, the examiner ask actually which is the best statin therapy for him. This was one of the questions. So as we mentioned, hydrophilic statins, rosuvastatin, bravastatin, ezetimibe, and other monoclonal antibodies. Okay. How are you going to investigate this patient? As you mentioned, basic, and then investigation to confirm the diagnosis, investigation to detect complication, and to search for the underlying cause. So I would want to do basic investigations, including CBC, renal function test and electrolyte, LFT. By the way, liver enzymes will be increased in case of muscle injury. So I would want to do basic investigations, including full blood count, RFT, electrolyte, and LFT. Then investigations to confirm the diagnosis. I would order creatinine kinase level, CK level, myoglobulin, and urine analysis. Creatinine kinase, by the way, is diagnostic in case of rhabdomyolysis. Often, it will be over 5,000 units per liter. Over 5,000. Creatinine kinase is very important. Very important. It is not only myoglobulin. Myoglobulin, creatinine kinase, both of them are necessary for the diagnosis. Then investigation to detect complication. Of course, ECG. ECG is very important to look for any features of hyperkalemia, for example, or features of arrhythmia. Arrhythmia, as we mentioned, starting from, it can be sinus tachycardia, and then other forms of arrhythmia like ectopic beats, atrial fibrillation, ventricular tachycardia, ventricular fibrillation. So I will look for signs of arrhythmia. I will look for signs of hyperkalemia. Like what? Signs of hyperkalemia like what? Any idea?
All tentative.
Okay. What else?
hyperacute T wave.
Sine wave,
PRF.
hyperacute T wave,
Yeah.
prolonged
Yeah,
QT.
exactly. Yeah. Long QT. Yes, exactly. Okay. So, by the way, hypokalemia will cause long QT also. Okay. And hypokalemia will cause U wave. However, hyperkalemia also can cause similar findings. So ECG to look for features of hyperkalemia and arrhythmia. If you mention ECG and then keep silent, immediately the examiner will ask you. This happened in the exam. Why ECG? To look for what? So from the start, mention each investigation you mention. Immediately mention why do you want to do this investigation? Because your plan of treatment has to seem sensible for the examiner to give you full mark within skill E. If you just mention investigation without explaining your ideas, he will not be able to understand why this candidate is mentioning all of these investigations. You need to connect your thoughts to the examiner thoughts. And the best way to do this is to mention why you want to do the test. In this way, he will understand that you are thinking in a sensible way, and he can give you the full mark in skill E. This is very important. So investigation to detect complication, ECG, as we mentioned, to look for any features of hyperkalemia or arrhythmia. Then monitor electrolytes, including potassium, calcium, phosphate. Consider renal ultrasound if there is any severe AKI, severe kidney impairment. Then CKMB or troponin if cardiac involvement is suspected. For example, if the patient has chest pain, yeah, of course, you will do troponin and CKMB. So investigations, I will start by basic, then investigation to confirm the diagnosis, CK and myoglobulin, and then investigation to detect complication, ECG, electrolyte, ultrasound, CKMB, and troponin, and then investigation to look for the underlying cause. For example, you need to assess his thyroid status. Do screening for any evidence of infection. Infection might cause or contribute to the development of rhabdomyolysis. You have to do infection screening. Sometimes you might need to consider toxicology screening if relevant, depending on your case. So what is your management plan? Again, you have to be well organized. Start by explaining the MDT. Treatment will involve a multidisciplinary team approach. Multidisciplinary team approach, including the nephrologist, including endocrinologist. Why endocrinologist? Hyperlipidemia, hypothyroidism, right? Exactly. Dietitian. So after explaining the MDT, I will move to acute treatment. First of all, this patient needs to be admitted to the hospital for aggressive IV fluids treatment, aggressive fluid therapy. To prevent what? To prevent or to treat, actually, acute kidney injury. The aim is urine output of more than 200 ml per hour. More than 200 ml per hour. Then monitor renal function, monitor and correct electrolyte imbalance. Monitor renal function, monitor and correct electrolyte imbalances. Then discontinue atorvastatin. Discontinue atorvastatin. This is very important. If you do not mention this, you will lose your clinical judgment. This is one of the main triggers here. You need to stop atorvastatin. Then you have long-term management. You will reassess whether you need to continue statin therapy or not. Maybe already his cholesterol level is normal, right? Reassess the need for statin therapy. And then if needed, you will need to switch to lower dose or give alternative. Most of the time, you will start alternative, like rosuvastatin, ezetimibe, and also in lower doses. Even these safe options, usually you will start them in lower doses if needed. And you will advise the patient, avoid overexertion and ensure good hydration. Avoid overexertion and ensure good hydration. Is it clear? So to be able to cover everything within any scenario within the long clinical consultation, cover your CCC and A. For this case, the patient have generalized body pain, muscle pain, tenderness, swelling, and stiffness all over his body, all over his muscles, shoulders, thigh, calf. So this is most likely rhabdomyolysis, especially within his past medical history. Mention some clues: statin, hypothyroidism. So when I come to the second C, I will look for any triggers: overexertion, dehydration, statin, hypothyroidism, overexertion, dehydration, statin, hypothyroidism, recent infection. Then confirm the third C. Did the patient develop any AKI, acute kidney injury? Is he dehydrated? Dizziness or standing from sitting position, postural drop in the blood pressure, any symptoms of electrolyte imbalances, arrhythmias, chest pain. And most importantly, also, you need to look for compartment syndrome and DVT. Compartment syndrome and DVT. Associations. Here, check hypothyroidism and thyroid status. For example, during your general examination, we mentioned that you need to palpate the thyroid gland for any enlargement, right? During your examination, vital chart, look if there is any bradycardia, any cold intolerance in the constitutional symptoms. So first C, rhabdomyolysis. Second C, overexertion, dehydration, statin, hypothyroidism. Third C, AKI, electrolyte imbalances, cardiac complications, compartment syndrome and DVT. Association, hypothyroidism and thyroid status. Is it clear? Is it clear?
Yes, yes.
Yes, clear.
Differential diagnosis.
Okay. Differential diagnosis here, the diagnosis is straightforward. However, differential is going to be for the underlying trigger. In this patient, it was positive for statin, dehydration, hypothyroidism, and overexertion. Okay. However, the diagnosis is straightforward: rhabdomyolysis.
For main complaint, can I say differential diagnosis like myopathy or myositis?
Actually, in rhabdomyolysis, you will have myositis, right? You will have evidence. Element of myositis, some muscle damage. Okay. However, in addition to cola, dark urine here, The diagnosis is straightforward. Rhabdomyolysis. Go search for the underlying cause. No need to think about other possible causes. I cannot think of any. The differential here is going to be for the trigger, underlying cause,
Thank you,
and
Dr.
whether
Hassan.
the patient developed complication or not. Welcome.
Yes,
Any question?
Dr. Yes, you
Yeah.
say when we start the history and ask the patient about the complaint, when it is one of the general complaint, you say one way is that to overcome this, but can you repeat it again?
Sorry, if you
You
can
say
repeat
to
your
ask.
question. I didn't get your point. Yeah.
When we face with a general complaint, we will not go to analyze the systemic review. First, we will ask about background without do analysis for it. Because I didn't get this point. If you can repeat.
I will just repeat or recap the approach. Okay. So when you enter inside, introduction, permission, open question. Introduce yourself, confirm the patient identity, and then permission. I would like to ask you a few questions, and I would like to examine you. It is not like we are here to discuss some issues related to your health. No, this is for communication. I would like to ask you a few questions regarding your health, and I would like to examine you. Permission. It is very important. And then open question. What brought you into the hospital today? What brought you into the clinic today? He will mention the complaint. Any other problem? For example, if he mentioned body pain, any other problem you notice? Yes, doctor, my urine is dark in color and of less amount. Then I will start analyzing one by one. Start by body pain. For how long? Duration. He will give you the duration. Regardless of the duration, what about before this duration? Were you normally okay? Is it the first time you developed this symptom? What about your health in the past? I will squeeze him in his past medical history because this will give you a clue about the diagnosis. For example, he will mention, I'm taking statin, I have hypothyroidism. So in addition to generalized body pain, dark urine, the diagnosis, you got the diagnosis from the start by just squeezing the patient in his past medical history. However, I am not going to take full history, detailed history in his past medical history. For how long have you been diagnosed with hypothyroidism? Which medication you are taking? Are you compliant to the medicine? Any history of side effect? No, I will not do this at this stage. I will just get the information to give me a clue. I will put this clue at the back of my mind. It will give me an idea about the diagnosis. However, if you do analysis at this stage, the examiner will comment that you are disorganized. So leave the detailed analysis for the past medical history, for the drug history. Okay? So after you squeeze him in his past medical history, immediately go back to your analysis. How did it start? Suddenly, gradually? Is it getting worse or better? Anything makes it worse or better? And sometimes, if the symptom is not general symptom like fatigue or not fatigue, sorry, like body pain, for example, if the symptom is not general symptom, you might need to add a specific analysis. For example, dark urine or any complaint related to the urine or any complaint related to fluid, actually. Here, quantification, content, compensation, complication. Quantification, content, compensation, complication. Is it clear? Did I answer your question?
Yes, clear. Yeah, but I mean that this question about before to start this specific analysis for the body generalized. Thank.
There is no specific analysis, just for how long has it been going over, how did it start, is it getting worse or better, and if it makes it worse or better, and is it actually sore or painful to touch your muscles? Maybe this is a single question you need to ask. Is it actually painful to touch your muscle or to squeeze your muscle? Okay.
Okay. Other symptoms, I can do this maneuver with it, and I can do the same approach with it. Like there is some
exactly. Any symptom has general analysis and then specific analysis. A general analysis is fixed for all. However, when you come to specific analysis, it will depend on the symptom. It will depend on the system. However, if this is related to fluid, I mean polyuria, diarrhea, vomiting, dark urine, then you can apply QCCC. Quantification. What is the quantity of his urine? How frequently do you go to the toilet? The amount of the urine, and then content. Is it bloody? Is it frothy? Is it? Do you pass any gravels in your water work, or it is just dark color? How dark is it? Is it like tea dark or cola dark color? And then after content, move to compensation. Do you drink enough water? Maybe he's just dehydrated, right? And then complication. Here you can ask about symptoms of uremia, for example. If the patient is having polyuria, vomiting, severe diarrhea, complication is going to be what? Hypovolemia and AKI, right? Is this clear?
Clear.
Clear, Doctor. Dr. Hussam, can I ask? I need to dig
Yeah,
more
please
on
tell me.
the hypothyroid causes or not?
Causes? No, it is not really necessary. You can ask within the post-medical history.
Okay.
You can ask within the post-medical history for how long have you been diagnosed with hypothyroidism? Any specific cause? What was the cause? In your
Okay.
examination, also, if you were able to detect any clear sign suggesting the underlying cause, it's okay. However, in this particular scenario, I don't think it is really necessary to dig more to identify the underlying cause of hypothyroidism.
Yes, because this is dark urine, makes the diagnosis easy, both of them. But with tiredness or the generalized body, I can think about hypothyroidism. But with this dark urine, the diagnosis
Yeah,
became more
exactly.
clear.
And
Yes.
also muscle tenderness, swelling, stiffness.
Yes.
Uh,
Okay.
yeah, it is not
Thank.
simple tiredness of hypothyroidism. Welcome. Okay, so any other question before we wrap the session of today?
Thank you, Doctor. Very nice.
Investigation need
Okay.
arterial blood gas for this patient. ABG.
Arterial blood gas, maybe to look for, yes, metabolic acidosis, you mean, right? To look for metabolic acidosis. Yes, you can mention this within investigation to look for complication or a general investigation.
Dr.
Okay.
Hassan, we need to examine the
Yes,
patient
tell me.
for sign of hyperlipidemia, xanthelasma, and like this because
Signs
he's
of
young.
hyperlipidemia. Yeah, okay. In the exam, in the exam it was not positive. And in general, xanthelasma, this is important. It's very, very rare to find them in the exam. Very rare. However, within your general survey, you will be screening the patient from his nails, hands, moving to the forearm, eyes, right? You will examine for parangioma. This speaks for all. Examine the neck for any thyroid in our scenario. Okay, if there is xanthelasma, you will detect it. Xanthelasma and also arcus pupil. Yeah.
Okay, thank you.
Dr. Hassan,
Welcome. Yeah, tell me,
want
please.
to ask, any, as you told, any hypermetabolic condition, we may expect weight loss, fever, and what about the appetite in hypermetabolic state? It will be increased or normal?
It can be poor appetite. It depends on the cause. Some cancers can result in hypermetabolic state. However, most of them will result in poor appetite, right? However, hypermetabolic state related to thyrotoxicosis, for example, will be associated with weight loss and good appetite. Diabetes, weight loss and good appetite. Malabsorption, sometimes weight loss and good appetite. Okay, so we'll stop here for today. Thank you for attending this session. See you next session, inshallah. Good night.
Thank you.
Kalazar, yes.
Thank
Okay,
you.
so goodbye. Thank you.